And get started. Hi, everyone. My name is Jenny Winkler, Director at the Illinois Health and Hospital Association, and I want to welcome you all to our first afternoon session around building antimicrobial stewardship programs in resource-limited settings. So we have a really great session lined up for you all today. So before we get started, I just want to take a moment to introduce our speaker, Dr. Rena Mathesius. So Dr. Mathesius is a manager of pharmacy operations at OSF St. Clair Medical Center in Princeton, Illinois, as well as OSF St. Luke Medical Center in Kewanee, Illinois. She's received her Doctor of Pharmacy degree from Midwestern University and has worked in critical access facilities for 13 years, as well as being an antimicrobial stewardship pharmacy lead for the last 4 years. So we want to welcome Dr. Mathesius, and I will go ahead and turn things over to you.
Thank you. Hello, today I will be discussing the core elements to a successful antimicrobial stewardship program and share some of the challenges I have faced in different phases of my career and how I was able to overcome them. I have been a part of AMS development from the pharmacy side since the CDC released its first set of core elements in 2014, and I've been a part of antimicrobial stewardship planning in every stage of development in multiple facilities. My entire pharmacy career has been within the walls of a critical care access facility, and I'm hoping that my experiences can help you continue to grow a meaningful program. I have no conflicts as stated. And our learning objectives today is to understand the 7 core elements for hospital antimicrobial stewardship programs, understand potential AMS roadblocks at smaller critical care facilities, and list 3 ideas for overcoming some of the obstacles to antimicrobial stewardship in a critical access facility. According to the CDC, the antimicrobial stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. So why is this program so important? It can help reduce risk of multi-drug resistance, decrease hospital-acquired infections, decrease adverse effects associated with antibiotics, promote timely discharges, decrease risk of readmission, and potential cost savings. The 2019 CDC core elements of hospital antibiotic stewardship include hospital leadership commitment, accountability, pharmacy expertise, action, tracking, reporting, and education. Even the CDC recognizes that there is no one-size-fits-all approach to optimizing this program. They even have called out small and critical access hospitals in an implementation of antibiotic stewardship publication geared specifically to these types of facilities. Overall, as small facilities, we have a common theme: comfort with the topic. In smaller facilities, we need to know a little bit about everything. It is hard to be an expert in a single subject, and infectious disease can be intimidating. Staying up to date on changes and guidelines can be daunting. Secondly, staffing. With staffing shortages and maintaining our bottom lines, it feels like we're working with less and less. So how can we ask anyone to take on something new? And lastly, overall buy-in. How can we push the CMS requirement to gain meaningful support from our upper management through to those at the bedside? Moving forward today, I'll discuss what obstacles for each of these core elements I have faced in my various experiences and how our team worked to overcome these. Our first element is hospital leadership commitment, and the CDC's goal is that we dedicate necessary human, financial, and information technology resources. Some strategies we can use include make leadership aware that this is a CMS requirement. Turn to your CMO, CNO, and pharmacy director for help with gaining momentum and support. It is key that they are to be accountable for the outcomes of the program through support on fallout review and creating a united front for your facility. Incorporate data review into other groups such as P&T or quality. This can help decrease meeting fatigue. These meetings generally do include our higher management, and help shine a spotlight on our wins or misses. Include program accomplishments in the annual report. This is another place to report our wins to gain attention from our CEO, such as decrease in days of therapy and decreases in healthcare-acquired infections. Even though we don't necessarily want to look at success in terms of overall decrease in antibiotic use or in terms of money, these could be persuaders for our leaderships by highlighting cost savings through our interventions. And lastly, training and education on what the stewardship is and providing an understanding of what this program is to accomplish is very important. Many speakers today had already alluded to the CDC and their many resources, and they do have quite a few resources geared towards different providers, even towards the CEO themselves, from posters and videos into CE opportunity. One of my obstacles has been the lack of understanding the importance of antimicrobial stewardship overall goals. When I was jumping into an already formed AMS, which was part of infection control agenda, I quickly noticed the point or purpose of AMS, to optimize the clinical outcomes for patients, was non-existent. Pharmacy was only reporting money spent and doses of antibiotics given. Once seeing this, I immediately went to a dashboard approach, which I'll show you an example of later. That was reporting more in lines of practice trends. And this was a fresh perspective and did gain notice in both infection control and P&T when presenting. We had many follow-up questions. This was my opening to make further changes. Another obstacle was lack of CMO participation. We needed a physician to help co-lead us. They are key to practice change, and a good participant is able to set a good example and then review cases with physicians one-on-one. One way I was able to improve this was appealing to the CEO for their buy-in or support. The CEO sat in our P&T meetings. Obviously, the CEO was invested in all outcomes of our patients. So when we started presenting the dashboard and reviewing drug utilization reports and the ways we were falling out, that got their attention. And this led to a stronger squeeze on the CMO to follow up on these fallouts on a one-to-one basis. Physicians attending P&T would also ask to see if they were on the fallout list. Awareness and accountability was growing. And lastly, lack of awareness hospital-wide. Again, the CDC has many great posters geared towards different departments. Along with those types of resources, I did review some basic topics such as culture review and IV to PO conversions at nursing unit huddles. I shared my AMS newsletter Hospital-wide, which I'll talk about more later, and I was also made sure to advertise changes with background of why. The next core element is accountability, and the goal is to appoint a leader or co-leader, such as a physician and pharmacist responsible for program management and outcomes. Some strategies to increase accountability include: create a policy that includes all 7 core elements and a reporting structure. Be sure to clearly define roles. Do not overlook the importance of physician involvement. Be sure to include other important players such as pharmacy, infection preventionists, microbiology, and nursing. Partner with offsite resources for support. Are there other facilities that can help with educational needs, patient reviews, or data gathering? For my facilities, when maintaining accountability, we were sure to create the accountability document, including the following outline. In this document, we clearly defined roles, what they are to be reporting, where to report out, and in general, what our goals are. We included the definition, purpose, design, organizational structure, and responsibilities. We also included a member list. This document was presented to our medical staff and at P&T. And this was also a good time for us to roll out a letter of support from the CEO. Physician involvement. We tend to lean towards the CMO as the physician lead, someone who has authority over the physicians. However, I learned at one facility, involvement, regardless of title, is at the very least key. The CMO was the appointed co-leader, however, was not in attendance or a voice for the stewardship. So I reached out to a physician who seemed to have an interest in the topic, and he gladly accepted. He even participated in the hospital's public podcast discussing antimicrobial use. He was a great spokesperson for the stewardship and willing to review cases with physicians. We were able to start making changes. Another obstacle I had was just being overwhelmed. In the previous slide, I did allude to these key players, and this is how they can help lessen some of the burden and help the program be successful. Pharmacy can review for appropriate therapy and provide recommendations as needed. These real-time education opportunities seem to have the biggest impact at any location that I have worked in, and this cannot be overlooked. Pharmacy is a key resource for providers. Infection preventionists have helped me review for healthcare-acquired infections and provide education to staff around such infections. Microbiology has helped me with data collection and creation of antibiograms. They have also helped to provide culture collection, education to nursing, and education of those culture collections to nursing who may collect at night. Nursing. By providing education at their unit huddles and include them in hospital-wide education, can have an impact on timely culture collection, culture result review, review of IV to PO potential, and even provide antibiotic use patient education at discharge. An example of how to use resources from the outside is how at one facility we had the pathologist from an outside facility that processed our labs be our chair for infection control committee and attend our AMS group. They were there to help review patients and collect data. They helped discuss our healthcare-acquired infections and even trends and resistance patterns. The next core element is pharmacy expertise. And our goal is to ideally appoint a pharmacist as a co-leader of the stewardship program to help lead, implement efforts, and improve antibiotic usage. This element has recently been titled medication expertise. However, they now specifically call out pharmacy. Some strategies here include build your pharmacist knowledge base with training courses. Some great CE opportunities and certificate courses can be found through the Society of Infectious Disease and ASHP. And there is also opportunity for Board of Pharmacy Specialty certifications. Provide appropriate resources. Easy access to guidelines are very valuable. I turn to guidelines supported by the Infectious Disease Society of America, the Surgical Infection Society, and the Infectious Disease Society of America, American Thoracic Society. And handheld resources are also a great tool when rounding. Collaborate with off-site resources for support. There are opportunities with larger facilities out there that you already partner with. Does your local teaching hospital or even another hospital in your system have residency presentations that they're willing to invite you to? Beyond the scope of educational opportunities, is there an option to partner with their infectious disease group to provide patient review and recommendations? It is common to do this with other specialty services, so why not infectious disease? And there's even telemedicine services geared towards infectious disease. And to start small, don't overwhelm with the need to know all. And I'll talk about how I used a stepwise approach with my staff. Personal obstacles that I had, one was growing the co-leader's knowledge base. And I have 2 points of view for this. For myself as a clinical staff pharmacist and appointed pharmacist lead, I soaked in as much antimicrobial stewardship geared CE as possible. I actively asked questions and participated in AMS meetings. I reviewed guidelines as I reviewed patients to ensure proper therapy was started. The more I used my knowledge, the more natural it became. I pushed myself to help review order sets. One of the biggest things I did for myself was to take on the challenge of creating a quarterly newsletter. It was meant to be a brief one-sheet review of common infectious disease process and the appropriate guideline treatments. I gained confidence during the process, and it became a well-received resource. What seemed like a daunting task became natural. Was I a pro at it? Absolutely not. And I have no formal training in infectious disease. However, I grew my knowledge base to know enough to ask questions and maybe dig deeper. More recently, as a manager, I have attempted to build and support my staff in a stepwise approach. We have made leaps and bounds over this past year to make our program more robust. We started small with pre-procedural antibiotic dosing, and we then moved to IV to PO conversions, never taking on too much at one time. And when I look back at previous program developments, this is where we started as well. During this period of growth, our facility was actually acquired by a larger health system, and I was then able to connect my staff to our health system's resources. I recommended starting the pharmacist out on a one-to-one basis with the infection disease pharmacist to review our patients until they felt more comfortable with the process and understood what to expect. They then began to participate in multi-hospital reviews and getting even more exposure to infectious disease discussion. They now had a resource to reach out to for support. My staff is now participating in interdisciplinary bedside rounds and is utilizing the opportunity to make real-time interventions. They are also working on their own newsletter edition on a topic of their choosing. To get us to this point, it has been about a year and a half. My other obstacle was gaining respect in this topic. This is tough as you're dealing with so many personalities. Success seemed to come naturally as we built on our implementation. Not only was my staff learning, but so were the physicians. We were slowly changing their normal practice little by little without overwhelming them. Being a constant voice and providing recommendation in a handshake stewardship approach really grew our relationship. The next core element is action, and our goal here is to implement interventions such as prospective audit and feedback or pre-authorization to improve antibiotic use. And these actions should be based on your facility's needs. Some standard strategies include team-based approach. Interdisciplinary bedside rounds was a great way to promote handshake stewardship. And then try to start small and expand in activities. These improvements, such as indication of use, IV to oral, even pre-procedural antibiotic dosing, helped build trust with the physicians and pave the way to move to more tricky pieces, such as duration of treatment and order set creation based on disease state. My obstacles were where to start and how to put these items into action. One of the first topics I had used to introduce antimicrobial stewardship in practice was adding indication for use to be required on all antibiotics ordered. It was a hard stop required piece on order entry. This began the discussion of stewardship. Preparing for implementation did require discussion with local IT and eventually directly with our software vendor. It was then presented in P&T with the background of antimicrobial stewardship explained, and it was our first step into tracking our prescribing habits. Pre-procedural antibiotic dosing was next. I picked this because it focused on a single group of doctors and did not overall change what was being prescribed, but rather just adjusting doses. I was also following up on a request for MRSA pre-op treatment options to be added to formulary that was started by the previous pharmacy manager in response to an uptick in post-op MRSA infections. There were more whys to ask here, and looking at our Vinco dosing, it was way below the recommended dose. So instead of adding the requested product, I brought updates to our current pre-op order set utilizing guideline recommended dosing for all antibiotics to P&T approval. Here's where the gap in the already formed group became very clear. The surgeon was shocked that I was basing all of our dosing on recommended guidelines. This was the first time we had attempted to change a practice in the name of AMS. I didn't walk away with approved order sets. However, an additional meeting with all surgeons reviewing guidelines and our goal in AMS led to approved updates and implementation. We also rolled out our first pharmacy dose adjustment agreement, allowing us to automatically adjust our pre-op antibiotic doses that did not meet the recommendations as outlined in our policy. IV to PO came next, and this highlighted pharmacy's expertise in pharmacokinetics as we created a policy allowing us to automatically change certain IV medications to their equivalent PO doses after reviewing patients for qualifying criteria. This was met with little resistance and was approved. I continue to bring AMS-related adjustments to P&T with every meeting. All requests were paired with discussion of AMS and the data I was collecting, followed by my newest order set adjustments. Not all order sets were a complete rewrite. A lot of the time it was just dose adjustments and the order in which options appeared, moving our broad spectrum choices to the end. Small changes, but steps in the right direction and drawing more attention to our cause. Guidelines referenced were always brought forward with these ideas for further understanding. During this time, I was providing these guidelines in the Y to my staff pharmacists. We were then able to connect with infectious disease from a larger facility, and we began patient review. These provided real-time education to the staff pharmacists. Infectious disease would couple the recommendations with a teaching opportunity and provide supporting documentation to further the knowledge of the staff. The pharmacists would then take these recommendations to our doctors. It was at this point we started discussion of duplicate therapy, therapy of choice, and recommendations based on culture review. Our goal was to review antibiotic therapy every 48 hours for appropriateness. Reflecting on this process, we realized as we rolled out each of these pieces, it became a part of our daily routine as we reviewed patients. What is the problem? What are my labs and supporting evidence? What are we using to treat? And how long do we need to treat? The more we answered these questions, the quicker the review became. We also became a more visible resource to the physicians and earned recognition as a valuable one. Sure, there were times we didn't know the answer, but we knew where to find that answer, and they appreciated that just as much as what we knew off the cuff. Our next element is tracking, and our goal is to monitor antibiotic prescribing, impacts of interventions, and other important outcomes like C. diff, infections, and resistance patterns. Data collection plays a critical role when assessing your program's actions. Be sure to tailor this to your site's needs. We want our measurements to be useful and help us to continue meaningful stewardship activities. We often speak of our small size as a negative. However, this really plays in our favor as our size allows us to track all the way down to the physician level. Engage IT resources to help gather data. This might be accomplished with your local IT. However, you may need to reach out to your software vendor to fully understand how to run or interpret your reports. I ran into this issue coming into a new computer system. I was more or less learning as I went, and the reporting was not all that intuitive. The time it took to make a phone call was well worth it. Use a simplified dashboard of antimicrobial use trends. Include days of therapy, IV to PO, broad spectrum antibiotic trends. We can really capitalize on our small size and be able to drill down for these provider-specific reviews. Work with infection control and track healthcare-acquired infections such as C. diff and any resistance patterns. And be sure to work with microbiology to create yearly antibiograms. This is an example of my AMS action plan. I use the year prior to help form a plan. I look for potential gaps or trends we may need to dive into deeper. Or maybe we find that we have held our positive trends and it might be time to move on to different goals. This time around, I added education. My handshake stewardship during patient rounds approach was going great, but I wanted to expand it and give them something that could be referenced. So the first AMS newsletter was born. I also did not see a huge change in overall days of therapy of broad spectrum use, so I wanted to deep dive and see if our most widely used broad spectrum, piperacillin tazobactam, was being prescribed appropriately. I did continue to watch for de-escalation of IV to PO for our most common infections. From my action plan, this is the dashboard that was created. Note that I use days of therapy per 1,000 patient days. Using days of therapy proves to be more useful than simply tracking doses given. With days of therapy, age, weight, or renal function differences in doses are irrelevant. This is defined as 1 day in which a patient was given a drug regardless of dose or frequency. There's little value in tracking overall doses or money spent. To improve broad-spectrum antibiotic use, I performed physician-level review of piperacillin tazobactam and if the patients met the criteria for broad-spectrum empiric therapy. I'll go over that in a little bit. But what I tracked is a percentage of patients appropriate for piperacillin tazobactam. I also tracked days of therapy for piperacillin tazobactam, levofloxacin, and ceftriaxone. Our overall hope was to see a decrease in our levofloxacin and piperacillin and an increase in ceftriaxone as we moved away from broad-spectrum antibiotics. For pneumonia and UTI de-escalation, I tracked ceftriaxone in terms of percentage of days of therapy with these indications and then tracked the percent of days of therapy of the oral therapies that would be appropriate. Our hope was to see an overall decrease in the IV and a trend up in the oral therapy. The trend in IV to PO can be challenging as we generally do not have critically ill patients with long durations of stay. Our patients might not qualify for conversion until their last day, so an equal decrease in IV might not be coupled with an equal increase in oral. It's important to look at our trends individually as well. As long as you keep your dashboard up to date, data gathering doesn't have to take a ton of time. On average, I would spend maybe an hour a month collecting and entering my data into my dashboard. I then take my action plan, dashboard, and graphs to P&T for review and discussion quarterly. They are very well received with questions regarding the fallouts and unfavorable trends. It is always important to think critically about our small numbers. Was there a reason for a sudden sharp increase, such as the start of flu and pneumonia season? These quick influxes can skew our graphs, and these antibiotics might be warranted for this time period. These graphs are created from my dashboard from the previous slides. With constant review at the individual provider level and education provided real time via newsletters, antibiogram, and drug utilization reviews, you can see our overall trend for appropriate use of piperacillin increased and our days of therapy for piperacillin had actually decreased. On this graph, you don't see a huge trend up or down when reviewing our broad-spectrum antibiotic levofloxacin with ceftriaxone. We had actually made great progress in decreasing our levofloxacin usage the year prior, and this year we're mainly making sure we don't see any regression. As you can see, we remain stable. Our graph showing IV to PO conversion trends for community-acquired pneumonia, you can see a more pronounced increase in trend for oral therapies, but not a proportional decrease in IV therapies. As we discussed earlier, this trend can be challenging as we generally do not have critically ill patients with long durations of stay, so patients might not qualify for conversion until their last day. Individually, we conclude that we are starting to utilize oral therapy before IV therapy. Here we can see our percent of days of therapy for IV versus PO, urinary tract infection therapy, as a positive trend as well. And we started to see an increase in oral therapies and a rather flat change for IV therapies. Again, thinking about this population, they generally have a shorter length of stay. And we're starting to see an overall trend to initiate oral therapy before IV. Our next core element is reporting, and our goal is to regularly report information on antibiotic use and resistance to prescribers, pharmacists, nurses, and hospital leadership. We need to share what we're tracking and our results in order to get any buy-in for our program. First strategy is to create a sense of ownership. Like I said, I took all these results to P&T with full explanation. Are there specific number goals we're looking for? No. We want to see trends. We cannot control how many or what diagnoses we have coming through our doors, but if we use our data appropriately, we can get a picture of our practices. My individual case reviews would get the most attentions, and physicians wanted to know if they fell out. They were beginning to own their processes as well. Add it to the agenda of an already formed group with keep the key players. P&T, quality, and infection control are some examples. For me, P&T was the most useful because I had the doctors present at this meeting. However, it does not mean that the other groups are not valuable, as they do help spread the awareness to our program and efforts. Antibiograms are a great starting place for detecting and monitoring trends in antimicrobial resistance. My number of isolates are small due to volume, but I still included some key organisms with disclaimers to interpret with caution. This gives them a starting point until full culture reports are available. You can also report isolates in a rolling 2-year calendar to gain a bigger number. I later expanded on this tool to become a quick reference guide. This is an example of a drug utilization review that I did as we were working on improving our appropriate broad spectrum use, as I had outlined in my action plan. I used a small time frame to keep data review feasible and looked at our usage of our most used broad spectrum antibiotics. I broke it out by days of therapy for each drug, and I then took a deeper dive into our most used piperacillin tazobactam and its indications for use. I reviewed each patient to see if they met healthcare-acquired infection criteria. Again, this is a small time frame, but what I found was that 26% of our days of therapy did not meet criteria. By looking at the percentage of appropriate use, it reflects a more relatable number than just showing a number of doses or number of days of therapy. I want to know who should not have been given broad-spectrum antibiotics as empiric therapy. And these results justified my continued tracking and my dashboard and continued discussions with physicians about appropriate initiation of broad-spectrum antibiotics. Next core element is education, and our goal is to educate our prescribers, pharmacists, nurses, and patients about adverse reactions from antibiotics, antibiotic resistance, and optimal prescribing. A lot of my education was coupled with my reporting of dashboards or DUEs. I had the luxury of having good physician attendance, and we had great discussion real time. However, there is value in this as you present to your physician lead so they can continue this discussion with other physicians. Some strategies to be successful in this core element include realizing the importance of real-time education. My facility had just begun to roll out interdisciplinary rounds and building on the AMS committee. Our rounding would consist of the physician, nursing, case management, physical therapy, and pharmacy. We discussed current state of the patient and what the discharge plan was. We were able to voice our questions or needs or concerns as individual departments to the physician and work on our plans. And this was a great time to discuss any stewardship needs. Be sure to be consistent. I had a particular physician that was consistently using ertapenem for all his patients. It was a single daily dose and did everything he needed it to. I discussed the use of carbapenems when discussing broad-spectrum antibiotic use and a more general outlining approach in a way that addressed all physicians, but that didn't seem to make any practice changes for this physician. So I decided to discuss it one-on-one. I outlined what he was most likely trying to cover and provided an alternative that would be appropriate. Of course, he fired back that this was all about money, and I didn't lie. His choice was much more costly. However, we talked about increased resistance in carbapenems, and we compared coverage side by side with my suggested alternative. We reviewed ease of conversion for discharge purposes. And of course, I didn't win my first attempt, but it got him thinking. And I was persistent and continued to provide this feedback. I was never rude or condescending, and I was just providing a recommendation with facts. Until one day, he finally did take my recommendation, and from that point on, I had gained his trust and respect, and he would text me for recommendations. It did not happen overnight, but I eventually was able to open the door. Try to keep it simple. Use easy to follow and concise information that is cited. We want them to know we are using reputable sources. Include education surrounding your audits and reviews. As I reviewed our dashboard results, I would tailor my newsletter or DUE according to what was needing improvement. It was much more effective to couple a problem with a solution, and I also included hot topics on our antibiogram, making it an even more useful tool. Engage providers to peer-to-peer education. Sometimes information is received better at this level, and this is where having a good physician champion is so helpful. My department has a good relationship with our providers, so pharmacist to physician discussions are not necessarily an issue. It is sometimes all in how you approach your physician. For instance, with my previously mentioned physician, I did not stand there and argue about his final decision, but I took the loss and tried again. However, if there are issues where you do not seem to be getting anywhere, a supportive physician lead is key to help providing education to those difficult providers. Look outside your facility. We already discussed learning opportunities from other resources. Don't be afraid to reach out to larger facilities to see what resources they may be able to share. Here is an example of what I used as educational tools outside of my real-time interventions. I introduced a simple newsletter. My newsletter was intended to be a quick one-page flyer outlining the most important clinical pearls, common pathogens, and guideline recommended treatment tailored to my facility's formulary. This was very well received. My physicians were saving it on their phones, nursing started requesting a copy as well, and what started out for just my facility ended up spreading to system-wide, and they were requesting it too. It was a very successful tool for us. I provided these newsletters quarterly, and once I got my template set up, it would take me maybe an hour of continuous work to put together, but generally it was pieced together when I had time. I expanded on a tool that was already in use. Our yearly antibiogram grew from just the hard data to being a reference source. This is just the one side of it, but it included the most common infectious disease processes for our site with brief treatment options. Some topics I've included in the past include community-acquired pneumonia, skin and soft tissue, urinary tract infection, allergy cross-sensitivity, healthcare-acquired infection approach, and C. diff treatments. The first edition always takes the most time, but the following years are generally not a complete rewrite. Make sure your guideline-driven treatment corresponds to the more recent recommendations. I would choose my bonus material based on any hot topics that I have been seeing in my facility. So what created a successful program at my facilities? Reflecting on my experiences, I would say building the program in baby steps allowed us to increase our comfort levels and to expand naturally for relationships to form. Secondly, ensuring education and resources are provided. Yes, I did grow my materials as I shared with you, but initially it was through my P&T write-ups. I did not just say, here, this is what we're doing. There was a full write-up containing guidelines and resources supporting it. It was an educational document in its own right, and this began my foundation for changes to be made. Handshake stewardship in real-time interventions. This is where, as a clinical pharmacist and as well as a manager, that I have seen the biggest impact on changes. Being a physical presence for recommendations and participating in bedside rounding makes the biggest impact in our success. Pharmacy ownership coupled with physician accountability. In all the facilities I have worked in and the facilities within the health system I'm currently in, pharmacy presented the plan and then implemented the plan through their interventions and recommendations. Pharmacy is the gatekeeper of the antibiotics and is the first to review its appropriateness. Pharmacy also provides tracking and prescribing education in order to promote positive physician practices. We then need the physicians to be accountable for their results. Our physician co-lead became valuable when needed to demand accountability, and our other hospital resources, as discussed further, helped our initiatives by providing needed education, data gathering, or interpretation with spreading antimicrobial stewardship awareness. So that closes my discussion on how we have grown our antimicrobial stewardship programs, and I will open it up for questions now.
Thank you so much, Rena, for running through that and sharing all of that with us. For those of you, if you have any questions, under the session tab, there's a spot where you can click on Q&A. So feel free to type any questions you might have for Dr. Mathesius. Again, really sharing, those experiences, if you identify a problem, coupling that with solutions, and also that experience you had with the physician pushback. That was a great story, because I know that's something that every organization faces. There will always be a couple of folks, pushing back on some of those changes and recommendations. So thank you for sharing that as well. And one of the questions that we did have was about the slides being shared from this presentation. And so all of the slides from the summit will be shared with everyone following today's event. So you all will be getting these slides. And in the meantime, maybe while other folks are coming up with a question, I know you mentioned taking small steps and just starting with small bits, but if for hospitals who are either looking to restart their program or kind of shift their focus back to antibiotic stewardship, what is the one place you would recommend that they start?
I would say making sure you have pharmacy, a strong pharmacy presence in it. From all my experiences, pharmacy really was the driving horse for our program, both in real-time intervention and just data and really accountability for the program as a whole. I think that's one way that I would definitely lean towards.
Okay, thank you for sharing that. So we're waiting on folks for another, maybe we'll give it a couple more minutes to see if folks have questions. Another question for you around demonstrating cost savings. What recommendations might you have for how an organization can do that, especially, a lot of our rural facilities who might have some of those lack of resources that maybe hospital systems have, or
well, there's always the raw data with your wholesaler and how much you're spending on antibiotics. This really doesn't prove that you're changing your practices at all, but it can highlight potentially some decrease in savings there that might appeal more to the CEO. Otherwise, if you can couple your interventions with maybe a degree of savings associated with them. I've seen that done before. Those are just a couple of ways that I've seen that. And then the IV to PO is definitely, if you can kind of track that piece, there's definitely savings in the IV to PO when you break it down by cost of tubing and all that fun stuff. Those are just some ways I have seen tracking costs and savings.
Perfect. Thank you. Thanks for sharing that. We'll give it another moment. If anyone has any questions, feel free to drop them in the Q&A section under the session tab on the right-hand side of your screen. We'll give it another moment. Okay. All right, not seeing any other questions. So again, Rena, thank you so much for sharing with us today. We appreciate you sharing your perspective and all of those strategies to meet each one of those core elements. So with that, everyone, the next round of breakout sessions will start at 2:35. So feel free to go ahead, take a break, get some water, and we will see you all at the next session.